So good afternoon, all of you here as well as on the Zoom. It's nice of Dr. Shaji to arrange this meeting for postgraduate students especially. And I'm sure you'll be able to get all the specialities to talk about various aspects here. Now, the topic I have chosen is congenital heart diseases, brief clinical tips. I have put it in that way so that you don't be misguided that I'm going to talk about all the congenital heart diseases in elaborate. I'm not going to. I don't think you should take down notes, because if you want, I can share the slides with you.
Get in YouTube.
No, not. I share it as a PDF or something like that. The PDF okay. He will do it for you. So I'll give you all of you. So please don't listen to what I'm saying rather than write down. Don't write down anything. That also can be for people in the Zoom. Don't write down anything, just listen. So I will be discussing only some tips and all regarding congenital heart diseases. And today I'm going to concentrate only on cyanotic heart diseases. So don't expect any treatment aspects or detailed clinical features and a pathology or anything of that sort. So Paul Wood, you would have heard of him, but he was our what you call as doyen of cardiology when we were students for MBBS and MD and then for DM also. But now, of course, Paul Wood's books are not even available for sale. But he is the one who initially said that when there is a congenital heart disease, ask 5 questions. Is this condition cyanotic or acyanotic? You should answer that. Is pulmonary arterial blood flow increased? And third, does malformation originate in the right side or the left side of the heart? Simple questions. Which is the dominant ventricle, left ventricle or right ventricle? And is pulmonary arterial hypertension present? First one was pulmonary blood flow, second is pulmonary arterial hypertension. If you can answer these 5 questions in most cyanotic congenital heart diseases, congenital heart diseases, whatever, you would have got near to a diagnosis. Now, 2 or 3 points which he has mentioned in those days. This book must have been written more than 50 years ago. Some of you wouldn't be born then. If 2 or more family members have a congenital heart disease, it is usually the same disease. We see ASDs in families sometimes. It is very rare for identical twins to have the same congenital heart disease. They may not have heart disease. One may have a congenital heart disease, and that doesn't mean the other should have. And in pregnancy, 5th to 8th week, this is most important. So please see that when you advise mothers, of course, it's not you actually, this should be told to the obstetricians, but they should know, be very careful 5th to 8th week, because this is so early that the heart starts beating by 6th week or so. So it's so early that it's likely that they even miss that they are pregnant. So you have to be very careful. Now, this is a quick classification. It's very easy for you. Cyanotic and acyanotic. And if you take the acyanotic, which I am not going to talk about today, it can be left to right shunts, stenotic lesions, or others. And I'll put a laser pointer here so it becomes easy for me. Okay. So if you take the left to right shunts, you have the pre-tricuspid shunts. Most important is ASD, all types of ASD. And you have what's the post-tricuspid, anything after the tricuspid valve would be VSD, PDA, AP window, or AV septal defects. AV septal defects, also called AV canal defects. And stenotic lesions, you have the left-sided aortic and aortic stenosis and coarctation. In the right side, you have the pulmonary stenosis, mainly. Let's not go into the rare diseases at all here, because we are dealing at a MD pediatrics level, not at a DM level. Others are regurgitant lesions like mitral regurgitation, which is more common. And what is L-kappa? Anybody? It is one condition where a child can present with myocardial infarction, isn't it? So these are the other conditions. Now, cyanotic heart disease. This is what I am going to take up today. Cyanotic heart disease, please keep the time because I don't have much. Low blood flow, increased blood flow. It's easy. And in low blood flow, you have with pulmonary stenosis, without pulmonary stenosis. A very simple classification. Now we'll go to some clinical approach. Now, how do you suspect that a child, infant, not child, infant has congenital heart disease? Congenital heart disease could be cyanotic, could be acyanotic. Child could have heart failure. Child may not have heart failure, whatever. So, what are the symptoms by which you suspect? If the child shows dyspnea during sucking, or if there is a flaring of the ala nasi. Now, these are things you know, but I'm just going in order. A rapid respiratory rate, time of onset of cyanosis. When was the cyanosis noticed? Second day of life, second month of life, second year of life, or second decade of life? That is important. Anoxic spells, you know what it is. Tendency for excess sweating is a sign of cardiac failure, isn't it? And crying on lying. You put the child on the bed, the child starts crying. You take the child on your shoulder, it stops being lifted up. Why? That is paroxysmal nocturnal dyspnea or pulmonary edema with the child, or it's showing orthopnea, but the child can't say that. Persistent cough at night, which is passed off sometimes wrongly as asthma, but may not be asthma. It can be asthma. I'm not saying it is never asthma, but any child getting recurrent night attacks, please see that there is no congenital heart disease. Recurrent respiratory infections, that you know, is usually a sign of left-right shunts, which are acyanotic. A decrease in urine output. Some parents may notice that. A chubby child, you may not notice facial puffiness, things of, I'm talking of congestive heart failure. It may be suddenly that they say the child is not wetting the diaper. So that may be a sign, right? And of course, if there is a family history of congenital heart disease, all the more you should have this in the back of your mind. Now, where did you get this word cyanotic? This is a Greek word. Kaunosis means blueness. Neelanaram. Okay, so that is how they got it. Now, when a child is born, a baby is born, transient acrocyanosis is said to be seen in some infants lasting for a few hours. You all see neonates, so you must be better familiar with it than me, right? Now, arterial desaturation means less than 95%. So anything less than 95% PO2 is desaturation. Less than 90%, you call it hypoxemia. That is decreased oxygen in blood. Okay, and less than 85% becomes clinically evident cyanosis in the presence of normal hemoglobin values. That is something which I am adding, because when hemoglobin is low, you may miss even this 85%. Now, what mistakes you can make, not you, pitfalls which can occur to anybody. When there is an increased pulmonary blood flow with cyanotic heart disease, the cyanosis may not be evidenced properly because the mixing is so much. Secondly, if the anemia also persists, then naturally, definitely you may miss a cyanosis. An acyanotic heart disease with a heart failure and a left to right shunt may show central cyanosis. So that is not a cyanotic heart disease. Patient is in heart failure. The cyanosis is due to heart failure, but it's a central cyanosis. Because of pulmonary congestion, the oxygen in the PO2 falls below 85%. A primary lung condition can present as central cyanosis. It can mimic a cyanotic heart disease, and a clinical assessment may be inaccurate depending on the hemoglobin status. That's what I told you at the beginning itself. Okay. This is a tricky term. I'm sure you would have all heard about this. Sometimes in cyanotic heart disease, rarely, very, very rarely, the upper limbs are pink. You can see the colors there. And the lower limb is blue. If you remember that, you will not forget that differential, right? Classical is a ductus arteriosus with a developing an Eisenmenger syndrome, because what happens? The cyanosis is in the lower limbs. So the desaturated blood flows more into the lower limbs through the ductus. a persistent pulmonary hypertension of the neonate, critical coarctation sometimes. Critical coarctation, there is ischemia of the lower part of the body. So there can be cyanosis, which really is not central cyanosis, but it looks like differential cyanosis. And hypoplastic left heart syndrome, very, very, very rare. So don't bother too much about this. Interrupted aortic arch syndrome, this is all part of the hypoplastic left-sided diseases. Now reversed, when you can have a differential cyanosis, you can have a reverse differential, where the upper limbs are blue. I think you can move a little this side. Social distancing, you are straining your neck too much. Right. Upper limbs are blue and the lower limbs are pink, just like that difference in color. Okay. And one condition, and usual, the only condition is TGA with a large ductus and PAH. If you forget this, it doesn't matter. This is only for completion, because I know it's a high-flown thing. Now, this is an important point which is worth remembering. If the rate of respiration is usually 40 to 60 per minute, cyanotic, the patient is cyanosed, the child is cyanosed. 40 to 60 per minute can be cardiac. But usually in respiratory, the rates are very fast. Rapid, shallow respiration. I hope I'm correct in pediatrics, right? 80 per minute, usually. That's what it is said. Respiratory distress. In a cyanotic congestion, you might have seen so many fallows tetralogy. They are not distressed unless there's a complication or so, unless they have a respiratory infection. But respiratory, they are always distressed, the child. Grunting, flaring, these are not seen in simple cyanotic heart disease, not talking of cardiac failure. Whereas in respiratory, it is always there. Child is really distressed. Intensity of cyanosis is very deep in cyanotic heart disease, but it's mild to moderate in respiratory. And if you give 100% oxygen for 10 minutes, that is a test. And ideally, you should do the ABG and all that. We leave all that complicated part. Cardiac, there will be only a limited response, because after all, it's a mixing of blood. So whatever oxygen you give, that mixing is not going to help. So there will be a limited response or no response at all. But in respiratory, definitely there will be a response and the PO2 will increase, isn't it? And a murmur with cyanosis is more likely to be cardiac than respiratory. The points are very simple. It's only, I think I have put many things together. That's all. Now, if you have a patient with central cyanosis, there are certain places where you should immediately investigate. Immediately means not in the middle of the night. Immediately means today or tomorrow. Don't postpone it for another 3 months. No, not like that. So the usually simplest thing without hurting the child is echocardiogram. No? If you find in a central cyanosis, PO2 is less than 50%, you must do an urgent. This is all urgent. You can't wait for too long. We have to intervene something. We have to do something. If you find differential cyanosis, it's usually a complicated affair. A murmur with the cyanosis, you have to do the echo as early as possible. And a cyanosis without respiratory disease. In short, these are all cyanotic heart diseases, but just I'm giving a different scenario where you must think of doing an echo as early as possible. Well, these are the simple things. Now, I'm just taking some groups. I'm not taking any individual diseases. I won't be discussing about them. Groups like, for example, cyanotic congenital heart disease with pulmonary stenosis and VSD. When cyanotic congenital heart disease with pulmonary stenosis, VSD, has right ventricular hypertrophy and a dextroposed aorta, we call it. Huh? Yeah, don't say TOF for the exam. Say fallows tetralogy. TOF is a short form. Of course, it is an accepted abbreviation, but not for an examination and not from a candidate. TOF is what you write in the case sheet quickly. Tetralogy of fallow or fallows tetralogy, isn't it? That is the commonest. Now, we used to be taught, even for DM, when we get a cyanotic congenital heart disease, we are supposed to start our discussion from fallows tetralogy, because the 85 to 90% of cyanotic congenital heart diseases, which we see at the age of maybe by 2 months or 3 months and all, will be cyanotic TOF, tetralogy of fallow, because all the others are not very rare. So your discussion always starts with this. And here also you can take that as an example. The patient has a progressive cyanosis from infancy. So as the child grows, the cyanosis increases. Now, when I said pulmonary stenosis, I was not meaning pulmonary valvular stenosis. It could be infundibular stenosis. And usually it is infundibular, or it can be combinations also. Those things we will not go into details. But if it is infundibular, it can progress. A valvular stenosis is usually fixed, whereas an infundibular stenosis, it's a muscular stenosis, can progress. Reasonably deep cyanosis is there. History of spells in infancy, squatting in childhood, no history of recurrent respiratory infections, and no features of congestive heart failure. Okay, so these are the things which will suggest that is, if you have these things, then you will think, okay, this is a cyanotic heart disease, possibly with a PS, and the blood is going from right to left through a VSD. That is how. Then you start thinking whether this is tetralogy of Fallot, tricuspid atresia, what you want, you can start thinking. So you start with the basic and then build up on that. Again, same group only. That was this was something like a history. And here, significant cyanosis on clinical examination, no heart failure on, this is all clinical examination, no cardiomegaly. So size of the heart is normal. Quiet precordium, a single second heart sound, and an outflow murmur of varying intensity. The intensity varies depending on the stenosis, isn't it? Now, congenital cyanotic, these are the names which you should know. It's enough, one or two you may have to read in detail. I won't be discussing any of these. Tetralogy of Fallot always tops the list of cyanotic heart diseases. Second would be pulmonary atresia with VSD, tricuspid atresia, double outlet right ventricle with VSD, transposition of great arteries with VSD and PS, AV septal defect, that is atrioventricular septal defect or AV canal defect, whichever name you want to use, single ventricle with PS, truncus arteriosus with PS. So everywhere the common factor is PS, and the other common factor is mixing of blood in the ventricle, isn't it? Then another group. I'm going group wise. That you could call it as group 1. Then you can call this as group 2. Group 2 is, I think you can read that top. Cyanotic congenital heart disease with increased pulmonary blood flow and pulmonary arterial hypertension. This pulmonary arterial hypertension is secondary to a reactive pulmonary hypertension due to vascular occlusions which occur in the pulmonary vascular bed. Okay, that is called Eisenmenger reaction. Now, I hope you know the difference between Eisenmenger syndrome and Eisenmenger disease. Well, we'll not go into it. This can occur, or it occurs usually in atrial septal defect, ventricular septal defect, patent ductus arteriosus, AV canal defect, and aortopulmonary window. These are all left-right shunts which can develop pulmonary hypertension and develop an Eisenmenger reaction and present as Eisenmenger syndrome, right? These usually start as a left to right shunt in infancy. Cyanosis is in the second or third decade of life, that is after the 10th year, maybe within 10 years, during the teenage or after the age of 20, except in ASD. Why? ASD, usually this occurs very late, or they go into adult life without developing any of the Eisenmenger syndromes, and they may end up with a congestive heart failure in the 7th, 6th, 7th, 8th decade of life. Because they can live even at 60, I have seen ASDs coming with congestive heart failure. So ASD has a totally different history. Cyanosis is mild to moderate, not as intensive as you get in tetralogy of Fallot of any pulmonary atresia, etc. There is minimal or no cardiomegaly. Again, ASD you may have cardiomegaly. No congestive heart failure in Eisenmenger syndrome. Clinical findings of severe PAH. I won't go into the clinical findings of severe PAH. I'm sure you know all that. Palpable P2, again one sign. Ejection murmur at the pulmonary area. That is due to blood flowing into a dilated pulmonary artery. EDM of again pulmonary regurgitation. EDM is due to pulmonary regurgitation. And there is no murmur of left to right shunt. In left to right shunt, in ASD, VSD and all, you will get murmurs. And VSD and PDA, you definitely get classical murmurs, pansystolic in VSD, the continuous machinery murmur in PDA, etc. These will be abolished when pulmonary hypertension develops. Now the third group, you can call it as group 3 if you want, are congenital cyanotic heart diseases with increased pulmonary blood flow, not Eisenmenger. So there is high blood flow, but cyanosis. Admixture, that means the blood mixed between the right side of the heart and the left side of the heart. This is due to mixing of systemic and pulmonary venous return due to common mixing chamber. That is, it comes into a common pool and mix and then it gets distributed to the right and left side. So that will be admixture lesions, like single atrium. When there is one atrium, anything coming from the left side, that is through the pulmonary veins or through the superior and inferior vena cava, everything mixes together and then gets distributed to the right and left ventricle, isn't it? Same thing in the single ventricle. So you just picture the, you must always, whenever you think of congenital heart disease, you must picture the heart as a simple square chamber with two septa, something divided into four. Truncus arteriosus, where the division is in the aortopulmonary trunk. Total anomalous pulmonary venous connection. The whole venous connection goes to the left side. DORV with VSD and PA, that double outlet right ventricle. So both the aorta and the pulmonary artery arise from the right ventricle. So naturally there has to be a VSD because the blood coming on that side also should come to the right side to be distributed. So these are all, there are obligatory ventricular defect should be present. Clinical presentation would be congestive heart failure in infancy. I'm talking about cyanotic heart disease with increased blood flow. No Eisenmenger. Okay. Mild cyanosis. Because it's a mixed blood, the cyanosis will be mild, not like tetralogy. Cardiomegaly. Because both sides are mixed. The right ventricle enlarges, left ventricle also enlarges. There is evidence of pulmonary hypertension. Again, when I say pulmonary hypertension, there will be a loud second sound and all, but it is not due to pulmonary arterial hypertension as in Eisenmenger. There will be a lot of murmurs, systolic murmur, diastolic murmur, sometimes what you call as a to and fro murmur, systolic or diastolic murmurs like in truncus arteriosus. These are things which you can always read up. You don't need a class for that. And of course, because the child is often in congestive heart failure, your child will be not growing properly. So there will be a retarded growth. This is some comparison I'm showing you. If a child presents with cyanosis, right, congestive heart failure, and ASD-like presentation. In ASD in a child, in an infant, will you get congestive heart failure? No, isn't it? Not usually. For you, it is not usual, not at all, right? But if a child giving clinical features of ASD has cyanosis and congestive heart failure, you think of TAPVC, which is total anomalous pulmonary venous connection, and singularity. This is only a differential diagnosis in a different way. Suppose a child comes with a simple presentation like a ventricular septal defect. The murmur looks like ventricular septal defect, but cyanosed heart failure. Then you think of a single ventricle and or a double outlet right ventricle. Not very difficult. If the child has a PDA-like presentation, again with central cyanosis and a congestive heart failure, think of a truncus artery. PDA-like means what will be the pulse like? Yeah, high volume pulse, isn't it? So that is what, when I say PDA-like presentation, the first thing which should strike you is the pulse. It's not over. Suppose there is TO, this is another, not those three groups. Suppose a child looks like TOF for all practical purposes. High, but high volume pulse is there. In TOF, the pulse volume is not high. it's normal volume or even low volume. So if the patient presents with tetralogy of Fallot with high volume pulse, suspect the presence of a large PDA or large collaterals, not collaterals, bronchopulmonary collaterals, large collaterals may give you a bounding pulse, right? So you can mistake now this for that, for PDA with flow. Pulmonary atresia with VSD and major aortopulmonary collaterals. Major means again large aortopulmonary. Some of the major blood vessels, like even the subclavian, may give branches directly to the pulmonary. TOF, where a surgery has been done, a Blaylock, Taussig, shunt, or there are so many others, water stent and all, forget whatever. If a shunt surgery has been done, so when you examine a child, if you are given a cyanotic heart disease, actually if you get a cyanotic heart disease for the exam, you will pass, because I'm sure the examiner will not know the diagnosis, unless of course he has been given a tip. Because the only thing is, if you look at the, always look at the back of the child if there is a cyanotic child, this site, right? Somebody would have done a Blaylock. Nowadays they don't do it. Nowadays everything is total repair. In our days, always we are asked to look at the back. If there is a scar, you ask them when was it operated. Most probably, and then if you see a bounding pulse, you passed with the first class, right? So see, that is how your general examination is very, very important. And TOF with aortic regurgitation, it's a rare combination. But if you have TOF with aortic regurgitation on auscultation, what will you get? Yes? Will you get a systolic murmur? You will get a systolic murmur. Why did you forget TOF murmur? It is there. TOF murmur, you will, in addition, you will get a diastolic. Say that. So you must say, in addition, there will be a diastolic. So in a TOF, in addition, if you get an early diastolic murmur, think of an aortic regurgitation. You have a dextroposed aorta, which can leak, right? Okay. So this is only just a tip, because TOF is not at all an uncommon cyanotic heart disease. That is why I'm saying. So you diagnose, for all practical purposes, you think it is TOF. Then suddenly you find that pulse itself is bounding. You must think of these possibilities, right? If you find a prominent JVP with features like TOF, think of tricuspid atresia, AV canal defect with PS, TOF with prolapsed tricuspid valve into VSD. That is, a prolapsed tricuspid valve will produce a tricuspid regurgitation, which will produce a prominent V wave in the neck. So if JVP is prominent, ask why. And these are possibilities. I hope I am not complicating matters. I am trying to make it simple. Now TOF-like features with a left ventricular apex. In TOF is which is a ventricle which is hypertrophied. That is part of TOF. No? So right ventricular hypertrophy is one of the components of a TOF. But if left ventricular apex is there, when you think it's a TOF, but left ventricle is prominent, think of tricuspid atresia, single ventricle, and truncus arteriosus. These are the three differential diagnoses. Many of these are what we have discussed before. I'm just giving you a little different permutations and combinations. A TOF-like feature again with apical murmur. Where in TOF, where is the murmur? At the apex? No. It is at the left sternal, right sternal border, the pulmonary area, etc. This area. Correct is rarer things. Corrected transposition with VSD and PS. Atrioventricular. Sorry. Hey, what's happening? Oh boy, I won't touch. No, I won't touch anything. Corrected transposition AVSD with PS and MR, single ventricle with a hypoplastic left heart syndrome. You can see that all these are complicated ones. So if you don't remember any of these, I won't mind. And obstructive total anomalous pulmonary venous connection. These are all rare conditions. Now we'll go into the ECG. That is something which I would like you to know, because sometimes everything looks like TOF, but the ECG is, something is wrong with ECG, right? Most important thing in the ECG here will be, one is right ventricular hypertrophy. I'm sure you know the basics of ECG, how to diagnose RVH, isn't it? You look at V1 and V6, two things. But do you know how to diagnose left axis and right axis? Since you nodded your head, you will have to answer. Yeah, just tell me, how do you diagnose? Simple. A simple method. I don't want you to draw a axis and all and calculate. Simply by looking at the ECG or touching the ECG. I'll show you a touch method also. No, axis. When I say axis, I'm talking of the QRS axis, which has nothing to do with V1. QRS axis is calculated using the limb leads, not the chest leads. I thought you were going to answer it. Okay, please. Anyhow, doesn't matter. You go. You go. Yeah, good. I won't ask you further. See, it is the limb leads which are important. Okay. So, a congenital tetralogy of Fallot, the axis is right axis. I'll come to how to show the axis. When I show the ECGs, it will be easier for you. So, tetralogy of Fallot has a right axis. If you get everything looking like tetralogy of Fallot, but the axis is left, single ventricle is a possibility. There are more, not one. So, cyanotic heart disease with left axis deviation. Tricuspid atresia, pulmonary atresia, transposition of great arteries, atrioventricular septal defect. Let's say AV canal defect with pulmonary artery hypertension or pulmonary stenosis. Both can produce. If the AV canal defects, you must have heard of ostium primum ASD, acyanotic, not cyanotic, acyanotic. There also we say it's a left axis, isn't it? Same thing, AVSD with pulmonary hypertension or stenosis will be left axis. Single atrium with pulmonary hypertension. Double outlet right ventricle with VSD and PAH. Sorry. So these are the ones which can produce a left axis deviation. So previously we used to say clinical examination is history taking and examination of the person. But now clinical examination encompasses clinical history, clinical examination of the patient, ECG, I mean in cardiology, not other departments, ECG and chest X-ray. Echo we can't include, then it becomes full exam. So these four, for examinations, it is the ECG and X-ray also should be taken into consideration before you give a final verdict, right? So see, left axis deviation, you must know this. So next question is, which are the heart diseases? Cyanotic, which will have right axis deviation. Tetralogy of Fallot. But remember, tetralogy of Fallot, the right ventricular hypertrophy will not have a strain pattern. You know what is a strain pattern, no? RVH with strain means the QRS axis, the QRS wave is very tall, the R wave is very tall, and the STT is in the opposite direction. Maybe I don't know whether I have an ECG of that. I'll show you. That is called strain pattern. In simple hypertension, which we see in cardiology, the patient can have what we call as LVH with strain. That is left ventricular hypertrophy with ST depression and T wave inversion. That is when the pressure becomes so high that the left ventricle is under strain. Same thing, when the right ventricle it is under strain, you can get right ventricular hypertrophy with strain pattern. That is, there is RVH, but at the same time the ST depresses and the T inverts. But in Fallot it cannot occur. You know why? Because there is a large VST there. When there is a large VST, the right ventricle cannot exceed the left ventricular pressure. Both are common. There is a big opening in the middle. No? So naturally, what is the pressure in the right ventricle and the pressure in the left ventricle are same. So the right ventricle pressure cannot go above the systemic pressure, which is the left ventricle. So it cannot become suprasystemic. You got it? Suppose I close the VST, or there is a condition where the VST is closed, but there is a pulmonary stenosis. It can occur in simple valvular pulmonary stenosis, which is severe, isn't it? Imagine, there is no ventricular septum. The ventricular septum is intact, no VST, sorry. Right ventricle is hypertrophic, left ventricle is normal. And it is the right ventricle is pumping against the pulmonary valve, which is highly stenotic, severely stenotic. Then the right ventricular pressure can exceed the left ventricular pressure. Then it develops strain. So in pulmonary valvular stenosis, you will get the strain pattern. So if you are given an ECG with a right ventricular hypertrophy with strain, it cannot be phallostetrology. You got the point, no? Whereas it can be, or maybe so many things. It can also be even pulmonary artery hypertension, but it cannot be fallow. In fallow, you won't get a strain pattern. I'm stressing more on the points for fallow because that is the commonest disease. Pulmonary atresia with VSD. This behaves like a phallostetrology. So there is RVH. So right axis. Again, a right axis can occur in truncus or also. In TGA also it can occur. TGA, VSD, PS. Pulmonary stenosis with VSD. Now you would have seen this TGA is coming there and here. You can get it in both. You can get left axis and right axis. So it may not be a diagnostic feature. Simple pulmonary stenosis with VSD you can get. Pulmonary stenosis with intact ventricular septum. This is what I told you. This you may get a strain. Not always, may get. If the pressure in the right ventricle exceeds the left ventricular pressure, which we call as suprasystemic pressure, you can get a strain pattern. Okay. Eisenmenger syndrome, again, if the Eisenmenger syndrome, ASD, all these, you can get a suprasystemic pressure. We'll go to the ECGs. Now I'll show you some ECGs. Just looking at the time only. Okay. No, this is simple. Now somebody said 1 and AVFO, she has gone for a call. Anybody wants to tell me the axis? This is, the diagnosis is at the top. This is not a quiz or anything. I'm just showing you samples, right? This is tricuspid atresia patient with an ECG. Tricuspid atresia ECG shows right axis or left axis? Right axis or left axis? Answer is in tricuspid atresia, is the axis right or left? I showed you about so many left axis, no? How do you diagnose? You have two hands. One hand, the left hand you place on the lead 1. Left hand here, right hand here. Who is positive? Not V1, lead 1. You place, I can't show you what I'm doing there. That's why I'm showing. See, I'm placing one hand here and one hand here, or one finger, right? This is positive, this is not positive, negative. It is left axis. If it is the other way around, this is positive and this is not positive, negative. This is right axis. If both are positive, it's normal axis. Simple, alla. Easiest method is to place your. Previously, we used to have this ribbon-like ECGs. Now we don't have that. It's all page. Ribbon-like ECGs, our process used to say just hold it like this. Lead 1 is held by your left side. First, lead 1 by your left thumb and lead 3 by your right thumb. Naturally, it's easy, right? So here, just you put your finger there, you got it left axis. Okay, we'll not go into the other parts. Left or right? Tricuspid atresia, another. Same, left. This is positive, that is negative. See, when one is positive, the other should be negative. Then only you can say left axis. If both are positive, it's not. It is a normal axis. If both are negative, what happens? What will you say? It is extreme. Yeah, it could be the axis could be somewhere in the right shoulder. It's an extreme right or extreme left. Some people call it indeterminate axis. That's a word. So it's very simple. Don't go by, there are calculations. If you want to